Good morning. Welcome to day 4 of Children's Week. I am glad you're able to join us this morning. My name is Caroline O'Corey. I'm a pediatric pulmonologist and a sleep specialist here at Stanford Children's Health. A few housekeeping notes. First, this session awards both CME and ANCC credits. You'll receive an email tomorrow from Stanford CME, from the Stanford CME office with instructions on how to obtain those credits if you're interested. Please use the Q&A button at the bottom of your Zoom screen to send questions to our speaker. This morning's session is on the clinical essentials of behavioral management of sleep in children and adolescents. We are pleased to have Dr. Rachel Manber with us for this session. Dr. Rachel Manber is a renowned behavioral sleep clinician and researcher. Clinically, she specializes in non-drug treatments of sleep problems in adults, youth, children, and infants. Dr. Manber has over 30 years of experience treating patients and conducting research to improve non-pharmacologic treatments of insomnia. She has led research projects and real-life initiatives to increase patient access to cognitive behavioral therapy for insomnia. Dr. Manber has a special interest in the treatment of patients who have long-standing sleep difficulties, including those who wish to stop taking medications, those with unusual sleep schedules, and those who experience their sleep difficulty in the context of other medical conditions or mental health concerns. So welcome, Dr. Manber, and I will turn it over to you.
Okay, let me share my screen. Thank you, Caroline. Good morning, everyone. Caroline already introduced the topic of my presentation. I will tell you what my goals are for today. Essentially, what I'm hoping to achieve is to provide you information that gives you a window into what behavioral sleep medicine, or otherwise known as sleep psychology, does. The interventions that I will describe are anchored in the sciences of sleep, of behavior change, on child development and family systems. And they're very specialized. And the caveat is that general psychotherapy may not be effective for insomnia. It's definitely not effective for insomnia in adults. I think child psychologists can use many of the principles we use to address many other behaviors to also address sleep. So sometimes general psychotherapy with a behavioral psychologist could be also helpful in the context of sleep problems. The interventions generally require a long initial session and a close follow-up. And that I'm saying because it is difficult, I think, to fold this in most people, most general pediatric practice, because of the practice model that is much more fast-paced with shorter visits, and follow-up is typically not as close as weekly. The interventions that I'm going to describe are very flexible, and they can be adapted to individuals who experience problem sleeping, or children and adolescents and adults who experience problem sleeping in the context of medical comorbidities, psychiatric comorbidities, special life circumstances, special work schedules, etc. And the focus here is going to be on pediatric insomnia. There are other pediatric sleep disorders, and I'm not going to discuss them here. If there are questions about them, feel free to ask, and both Caroline and I can chime in and answer them. So to start with, I just want to tell you a little bit about the research, very little, that's the one slide, about the research, overview of the research in pediatric sleep disorders. There was a review by Meltzer in 2021 that identified 120 RCTs on behavioral interventions for pediatric sleep problems. However, most studies were conducted among typically developing children, and most focused on very young children. Only 7% have school-age children, and only 8% have adolescents. My research has taken me more into the research in my lab, at least with my postdocs, on adolescent sleep and how to address it using scalable interventions. The samples include primarily Caucasian participants, which is another strong limitation in the literature, and there's little information about cultural factors. Yet, as you will see throughout the conversation today, cultural factors are very important. So in general, the outline of my presentation is that I'll talk a little bit very generally about how sleep is regulated, because I think having that framework can help you think about any problem that comes your way, regardless of age group. And then I'll start walking you through infants and toddlers, and then discuss general cognitive behavioral therapy for insomnia, because once you pass infant and toddlers, essentially CBT for insomnia principles combined with behavioral modification for general behavioral sleep, behavioral issues with children and adolescents combined together for the other age groups. So we'll talk about school-age children and adolescents. There will be, rather than traditionally you listening the whole time and then have opportunity to ask questions, I'll take some breaks and ask questions on a particular topic so we can have a discussion interspersed throughout, so you don't get listening fatigue. So the sleep regulation includes three processes. The first two processes are the homeostatic sleep drive and the circadian biological clock, which together constitute what we in sleep research call the two-process model of sleep. In addition, there is the sympathetic activation of the arousal system that interacts with the sleep system. So I think in order to really think thoroughly about the process of sleeping, one needs to talk about these three processes. So let's talk about each of those. So let me orient you to this complicated slide. If we're now talking about the homeostatic sleep drive, I'm talking to physicians, so you all know what a homeostatic process is. So essentially the principle here is that the longer time the person is awake, the more the brain accumulates adenosine as a byproduct of using energy, brain energy, and which signals to the brain that energy needs to be replenished through sleep. So it is an oversimplified model, but the idea is that basically as the day goes by, if you think of the down arrow in here towards sleep, the drive for sleep increases, and when the person goes to sleep, so this is the sleep period, the diffusion of the sleep drive, and then it starts increasing again. So the piece that I'm adding here in this text box is that not only as the sleep drive increases, subjectively, the person will end up feeling more and more sleepy unless something is opposing it, right? So as the day goes by, the sleep drive increases, and this typically would translate to increased subjective feeling of sleepiness. And at night, it will be translating, when you sleep, it will be translating to feeling of alertness. One of the opposing factors that make sure that we don't feel so sleepy during the day as our sleep drive accumulates is the circadian regulation of sleep through the circadian clock. The clock basically runs on average of 24.2 hours. And the output from this clock is sending alerting signals of increasing magnitude throughout the day and decreasing across the night. And so if I am to show you the same type of picture again, if you think of the arrow now going up towards wake, it is opposing what was there before, and I'll put the two slides together in a minute. And then when it gets dark, then the magnitude of the alerting signal decreases, which is an optimal time to go to sleep. If you try to go to sleep here, then you'll still have opposing forces from your circadian clock. And then at a certain time, the clock starts increasing the alerting signal, and then the balance tips in favor of the person wakes up 1 to 3 hours later. I put in here the word T-mean, and the reason I put it in here, because I don't want to go into too much details into the biology of the circadian clock, but one of the ways that we study it is by looking at the core body temperature minimum. And that corresponds very nicely to the magnitude, the inflection point of the circadian clock alerting signal. And that will become important in one of the two slides that's coming up very soon. So putting it all together, if you look at the day and night, and so this is the day and night is very clear, and this is the period of sleeping here. The sleep drive, since the person increases throughout the day, the clock opposes it, and the magnitude of the blue arrows is longer than the magnitude of the brown arrows, and the balance is in favor of staying awake. When you start decreasing the signal, the alerting signal, this keeps increasing and the balance tips over to the sleep. What keeps you asleep is the fact that this decreases as well, so the balance remains here, and when the inflection point comes back, then the person wakes up. And so this is how the two processes work together. So what happens when there's a misalignment between the circadian clock and society's clock, or the clock on the wall? So if you take a typical sleeper that sleeps from 11 to 7, perhaps their T-min, the point of inflection, will be at around 3 o'clock or 4 o'clock in the morning, 4 o'clock in the morning, let's say. On the other hand, if you have somebody who has a delay in their biological clock, the minimum will be delayed. So what would it translate to? It would mean that when they are trying to go to sleep at a time that is socially acceptable, their clock is still, the arrows are still too strong, alerting, and therefore it's difficult to fall asleep. And in the morning, it's difficult to wake up because the alerting signal have not increased sufficiently. And I would say really what the telltale of somebody being most likely with a delayed clock is the difficulty in waking up in the morning. So these people are characterized sometimes as night owls. On the other extreme, you have people whose sleep phase is advanced, which means their minimum is much earlier. I exaggerated here and put it at 1 o'clock in the morning. When they are trying to push their bed later, it's difficult for them to maintain alertness, so they end up going to bed earlier. And then they wake up very early and they cannot sleep anymore. So these are people who call themselves larks. However, clinically, fewer people present with the problem of waking up sleeping early because it causes less functional problems during the day. So I think we'll focus today on, in that regard, on adolescents, where the issue of having a delayed phase starts emerging more clearly. So I'm asking you to reflect based on what you've heard me talk about and think, what is your personal circadian type? Are you more of a night person, more of a morning person, or neither? And so I think we're going to start a poll here, and please put in the number 1 for night person, 2 for morning person, and 3 for neither. And perhaps we can tally and let you know what's the distribution and how it compares to the distribution out there in the world that we know about. So while you're doing that, let me give you a minute. Okay. So what we found, are we done? We have the final vote. Okay. This is very interesting because this is very different than what it is in the general population. In the general population, you have maybe 25% in each of extreme, and the majority, 50%, kind of sit in the middle, depending on how you cut it. But there could be, I think this is a very interesting result as we're looking at it, because it's difficult to type oneself because they are both biological and behavioral factors. When we come to talk about the adolescents, we'll be able to come back to this point. So now let me talk about the third process, which is the arousal system. So the arousal system or the sympathetic nervous system can trump the sleep promoting system. And this is evolutionarily adaptive because it allows us to respond to danger and therefore pass our genes, right? And so, however, modern day threats and dangers are different than prehistoric time dangers. And so if it were the hyena outside the camp at night in prehistoric time, in modern days, it's the stuff you need to do tomorrow, worrying about your performance, worrying about what you said. The sympathetic nervous system, it doesn't matter to it what is the threat. It has one system that responds to threat, whether it's imagined or real. And so when you have an overactive arousal system, it can interfere with the two-process model of sleep and makes it more difficult to sleep. So hyperarousal can be experienced in a variety of ways. There could be an activation in the sympathetic nervous system by emotions of both positive and negative valence. When people are in love, they are very excited and they can't sleep, or any positive event that causes excitement just as much as if they are in a state of anxiety. There is also cognitive arousal, which is in the context of sleep, trying to sleep, putting effort into sleep, performance anxiety, worrying about the consequence of poor sleep, or fears in the case of children, very important to include. And the last source of hyperarousal that can interfere with sleep is conditioned arousal, which I have the next slide talk about, which is the idea that over time the bed has become a cue for arousal. Whereas under normal conditions, if you think about the two-process model, it runs in the background and sleep is an automatic process. And the moment we put effort into trying to sleep, we're interfering with an automatic process. And I think all of us can reflect into times in our lives or situations where putting too much effort creates hiccup in something that if you just don't think about, you do very smoothly. So what is conditioned arousal? Well, it's very akin to Pavlov's dog training to do classical conditioning by having the dog salivate at the sound of the bell. So basically the idea is you bring the dog food, normal reaction is to salivate. You bring the bell while you bring the food, and over time, you don't, so you bring the bell when you are bringing food, and over time, what happens is you only need to ring the bell and the dog already starts to salivate. So in the context of the bed, over time, with repeated pairing of tossing, turning, being frustrated, being upset that you're not asleep with the bed, now you go to bed, you've not even yet started trying to sleep, nothing has yet happened, you already become anxious just at the side of the bed. And that conditioned arousal need to be extinguished if we were thinking of the three-process model. And in the language of pediatric sleep, I think this most relate to the concept that you're all familiar with, it's called the sleep association. And I'll get to it later. There's a very strong evidence that people with insomnia have higher hyperarousal across all domains that I discussed. And I want to highlight here two three actually studies. One is that if you do something that we call the multiple sleep latency, which means you give a person an opportunity, 5 opportunities to sleep throughout the 24-hour, throughout the day, and you measure how long that it took them to fall asleep, and the opportunity is 20 minutes. So if you didn't fall asleep, then you get a score of 20. If you fell asleep in 5 minutes, you get a score of 1 or 5. And so then you average across the 5. So a smaller number would mean minute to fall asleep is less, which means you're more sleepy. Whereas if it's more, then you have higher arousal. And so when you compare people with insomnia to people without insomnia, they take longer to fall asleep when you give them naps. In fact, most of my patients, if I ask them, do you nap? They say, I can't. If I wanted, I couldn't. And so in some ways, insomnia is the inability to sleep in face of even having a strong sleep drive, right? There's also a model of insomnia in which you use a caffeine-induced insomnia. You take people who sleep well, you study them with this MSLT, and you compare them to controls, and when they have caffeine in mind, they cannot fall asleep during the nap. So that kind of evidence for that arousal going on here. What is interesting, however, is that if you take people who sleep well and simulate insomnia for them, which means you study 10 people, let's say 10 people with insomnia, and then you yoke each person to a normal control. And then you bring the control into the lab and you say, and you make their sleep look like they're yoked individual with insomnia. So they sleep just as poorly. If the person with insomnia took an hour to fall asleep, then you don't let the person, the normal person, sleep until an hour later. And if they woke up after 2 hours and were awake for half an hour, then you will simulate that. You can imagine that there are some technical challenges in doing this kind of study, but the end result is that if you take people who normally sleep well and you distribute sleep to be similar to what an insomnia person experiences, a person with insomnia experiences every night almost, what you see is they are very different. Their time to fall asleep in the nap is much shorter than normal control, than themselves before and than normal controls, because for them, there isn't that hyperarousal. And so what they experience is just sheer sleep deprivation without the hyperarousal opposing it. So that kind of all of these studies together tell you that the arousal masks the underlying sleepiness that I talked about earlier, when I say that the stronger the sleep drive, the more subjectively you feel sleepy, unless you have arousal opposing it, right? And the other piece that it highlights is the fact that people with insomnia experience hyperarousal in the sense that they are tired, they need sleep, but they feel wired. So the expression of tired by wired is an expression that many people in insomnia really feel like if you say that, they feel you really understand them. So to summarize the sleep regulation, in order to sleep well, 3 things need to happen. The sleep drive has to be strong. And you can think about things that can make it weaker, for example, a very long nap or a very late nap. The placement needs to be correct relative to their biological type, or you adjust their clock, and the arousal level need to be low. And when all this happens, we all sleep well. And if any one of these is off, then we're having trouble. And so when we think about a person who has trouble sleeping, we need to think about all of this. So let's have a pause for questions, if there are any. I only see one Q&A there and one chat.
Yeah, so far we have, it's more coming in. So the first question is, what do I do about this conditional arousal?
That's coming. So I will talk about it.
I love it. Stay tuned. And then the next question I think is also, related, which can the circadian clock be reset?
Yes. So the circadian clock is reset, and you all know it because you can travel to a different time zone and your circadian clock resets, right? So what you cannot control is the biology of what determines the circadian typing. So I did not talk about it, but there is a strong genetic component to the circadian type, and it all relates to that oscillator that is the circadian clock. At the time between minimum and minimum is the period of that oscillator, and there are genes that control that period. And when the gene is for a longer clock, for a longer period, then the subjective experience phenomenologically, the person is a night person because so without the because, and if it is shorter than 24 hours, then the person experiences it as being a morning person. So we cannot change our genes, but what we can change is we can entrain every day. We are entraining our biological clock to the rotation of Earth around its axis. basically. And this is done in the system by sensitivity to multiple cues. The most prominent of them is light. And the second one is being up. So the ears getting the sensation that you're up in a vertical position already helps tune it. So the timing of when you get light exposure and when you're up and active regulates that clock. And that is how behaviorally we naturally change the timing of our clock from one time zone to another. And what happens with teens is, or with people who work shift work, is because they have a virtual jet lag in essence, because they change where they sleep at different days, during periods of transition, the oscillator is confused, and the magnitude, if you look at the oscillator and it has a nice amplitude, the amplitude becomes dampened. And so that results in a very weak biological clock. And that is the reason why we typically say that irregular schedule is not a good idea, because basically what it does, it removes the amplitude, it reduces the amplitude, which means if you think of the biological clock as a bass player in an orchestra or in a band, the whole orchestra falls apart if it doesn't have a good timekeeper, right? So it's the same thing happens with our sleep and wakefulness. Is there any other question?
A few. I love that analogy of with the band. Thank you. I'm probably going to use that. I have a few more questions. We have, what are some cultural significant factors which can impact sleep?
Many. So first of all, the attitude about the value of sleep and the value of being regular changes from one culture to another. Some cultures kind of go with the flow, and some cultures are more structured. So there's the structure that comes into place. I don't know if I will come back to more cultural factors that have to do with attitudes about child sleep in particular. So maybe I'll stop here so I have more time for that.
Great. And we have a couple more questions. I think we still have maybe 2 more minutes for some, but one, someone was asking, is it possible to be neither a night owl or a lark, essentially saying,
yes,
we tend to stay up late, but here's a caveat to the question, staying up late, but still waking up early and feeling tired all the time?
Well, if you stay up late and you wake up early and you feel tired all the time, you're sleep deprived. So it has nothing, so basically you're not allowing enough opportunity for sleep. So that's another problem in our society, but it's not sleep. It's not a disordered sleep. It's just insufficient opportunity for sleep. And I would say, yes, the majority of people can push through because the arousal system is very strong. We can override a lot. We can withhold food, we can withhold sleep, and we function. But at some point, there's consequences. Last question.
We have more, and we'll get to these later, but maybe we'll do one more question now. I think you were going to kind of get to this later, but one is questions. Do you agree with the societal norms that children no longer need naps after 5 years old? They have a 10-year-old patient whose parent makes them take a nap, and her appetite signaling seems to be off because of this. So this person would like to recommend they stop forcing the nap but they want to make sure that's an appropriate recommendation.
So we actually don't have data on that. I'm going to show you data up until 36-month-old. What's the norm and how things are changing. In general, the challenge is the construct of sleep need. And I always took it for granted that I know what it is until I wrote a book and the editor asked me, what is sleep need? So I needed to kind of dive in and to think through that and to define it to my readers. And the best way that sleep researchers talk about sleep need is by examining the amount of sleep that you need in order to optimally function. So I think the best way for you to think about this case that you're talking about is what is how well is the kid functioning without the nap, and what are the costs? So you also do a cost benefit analysis. What is the cost of sleeping in the daytime and the nap? If you sleep in the daytime, most likely your sleep at night will be shorter because we really have a budget over 24 hours. And so if you don't this parent might have discovered that it's better for their child to do it that way for a variety of reasons, but I will do a functional analysis of the whole thing and try to reason along the lines of what's best for the performance of the child. Okay, so I'll move on to infant and toddlers, and I'll talk about a few slides about what we know about the development. In between 0 and 6 months, we focus on prevention. We don't do interventions at all. I really strongly recommend against. In this geographic location, I'm hearing more and more people are trying to sleep train their infants at 3 months, and I am shuddering a little bit at that. And then I'll talk about some interventions starting at 6 months or older. So I'm presenting here, there's many studies on that, but here I'm presenting data that comes from a study that Jodie Mindell published in 2016, in which she has asked parents to, using a mobile app on their phone every day, to record the amount of sleep and the timing of sleep and a whole bunch of other questions. So it's a large, that's why it allows her to sample a large sample of individuals, and they did it over time, and people could enter the study at different age groups. So for different graphs, there'll be different number of participants in them, so it's not all 841. And what you can see, I'm going to show you one slide on night sleep and one slide on naps. So what you can see from this one is you can see that the duration of sleep is at the x-axis, and the y-axis is the frequencies. It is the number of people who, the number of children who sleep that much for each duration. And what you can see, the first thing that you see is this nice normal distribution started to emerge at age 10 to 12, but it's really strongly there at 1 year. At 1 year or at 10 months, you already can start seeing a normal distribution. You can see that the mean moves to less, which is, of course, we know that. And what the other piece that you see is this very large distribution, a very large individual difference. So there's at age 5 to 6 months, you start seeing more of a pattern, which is that second pattern. And then at 6 months, there is greater consolidation. So this is really when you start seeing a normal distribution. And for most children, if you talk about the median or the mode is at around 7 months. The other thing that's not displayed in this image that came from this study is that the data definitely show that the way kids sleep longer is by going to bed earlier. You can't really push kids to sleep in later, probably because the way the biological clock is set. But in order to achieve longer sleep, the key is an earlier bedtime. And this slide tells you about the development of napping behaviors. And here, the data extends all the way to 22 months. And what you can clearly see is initially sleep is across the 24-hour days, and there isn't, when you average across people, it's hard to find time of day in which things are happening, like very distinct. But around 8 to 8 months, you start seeing 2 distinct naps, and you can see how they are more or less at the same amount, but slowly this morning nap disappears and you get a longer later nap. And interestingly, you start getting back into chaos the older the kid gets. And so fewer, because of the individual variability. So some kids don't nap at all, some kids nap at different times. So during that transition, which is very difficult because when I talked about sleep need, the kids need sleep oftentimes, but it's more difficult to control and to get them to sleep. So that's all I want to say about that development. I want to show you a little bit data from a study that did qualitative interviews with parents about their interaction with pediatricians around sleep. And there are 2 things that I wanted to highlight. One is this one. I've asked many pediatricians and everyone just said it's okay. They told me the problem will be alleviated as time goes by, and they thought I was too nervous. Actually, they didn't help. So I think that it's a very complex statement in here. And I think that the challenge for pediatricians is, in most cases, it is indeed okay. However, it's not helpful to tell the parent that they're too nervous. It's more important, it is very important to listen to them, understand, and answer them at the level of their concern, without labeling, of course. And it's very challenging to know when to so oftentimes that reassurance is actually all that the parent needs. But for some people that are particularly nervous, this is actually backfiring. And even though the pediatrician may be very right that the person is very nervous, that statement alone is not helping the nervous person, and they need more help. The second piece I want to highlight is the statement, I think that it relates to the baby's own innate temperament, and so I have never ever asked about sleep. Babies are what they are. And I'm putting this in because in my line of work, it's extremely interesting, and we are very attuned to parental cognitions and attributions about their child's sleep. And so they're generally, and I'll come back to that. So before I do that, I want to give you, begin the setting the stage for the infant sleep development. So between 0 and 6 months, we do not intervene, we set the stage to encourage good development. So basically what we do is we provide information about infant sleep development. We highlight that there are different individual differences in duration, distribution, and level of consolidation of sleep. Parents compare notes, and that's not necessarily helpful. We talk about the development of sleep, internal structure, and so that it's too soon to try to impose too much intervention, because the brain is still developing. Initially, there is just 50% of the time is spent in active sleep and 50% in quiet sleep. And over time, there is a differentiation of the quiet sleep into what's known as the non-REM sleep stages, and the different stages emerge over time. And then the active sleep becomes the REM sleep. So we talk quite a bit about that. And most importantly is to talk to people about the fact that all infants wake up, and the difference between their friend who tells them that their child sleeps through the night and their own child that might not sleep through the night is whether or not the baby is signaling to their parents that they're awake. So we are really making a strong distinction between signalers and non-signalers. The research is showing that infants who sleep through the night still wake up, but they can self-soothe themselves to sleep without crying to alert their parents that they're awake. And phrased in the terms of learning to self-soothe is something that most parents want, particularly when the parent is very nervous. A parent who's very nervous is lacking in the skill of self-soothing, right? And so they very much don't want their child to inherit that quality about themselves. So talking to them in the language of self-soothing is very helpful to help motivate them. We also talk about identifying early signs that the child being tired and needing sleep, emphasizing that unlike adults, when we are sleepier, we become slower moving and slowing acting. An overtired kid becomes hyper and has and as a result has harder time to settle. So if if you don't catch them when they just start needing to sleep, it's going to be harder for them to fall asleep. And for the middle of the night, distinguishing when the child cries, whether the child is in distress or the child just wants company or whatnot. And perhaps Caroline, I borrowed this statement of the parent as an expert from Caroline, because she was saying how helpful it was to talk to a parent who didn't know what to do, to say, well, you're the expert, you know your child. So I think this is an important attention pointer. The other thing that we do is we want, the principles around here is we want to promote strong sleep association. We want the bed to become a good cue for sleep. And what helps in creating that, again, we are doing promotion right now, is to create a consistent bedtime routine, to have a sequence of activity that repeats itself, like bathing, feeding, reading, or whatever it is, and close parentheses. And also create environmental cues. So the room becomes dark, there might be certain music you put on, or a white noise machine, or you put the kid in a special apparel. And all of these are very strong cues for the kids to associate with sleep. Another principle is in the nighttime, avoid overstimulation, minimize interaction, minimize light exposure. I think this is the part that most people get very clearly from their pediatrician and from what they read, and they're following fairly well, but not all. And the important piece is help the child to self-soothe. And how do you do that? Well, one technique that's strongly recommended is to put the kid down at bedtime in a state of drowsy but awake, rather than wait until the kid is fully asleep before putting them down into the crib. Not to mention that if you are holding the baby and the baby falls asleep and they are not yet in the deepest stage of sleep, and you try to put them in the crib, they'll wake up. And now you're teaching the opposite. And the other piece is to suggest to the parent to slightly delay the response to the child's wake. So wait a little, wait a minute when the child fusses, or 2 minutes, or whatever you can tolerate, before going in and intervening, because that will give the kid an opportunity to self-soothe back. Whereas if you intervene too early, you might deprive the kid of the opportunity to teach themselves that. There's a very nice study, again by Jody Mindell, about 6 to 36-month-old baby. And they targeted, now we're talking about intervention in an older group of kids. And the intervention was aimed at people with mild to moderate problems with sleep. It's not supposed to be for the severe cases. So basically, it's an internet-based intervention whereby the parents initially have a baseline where they monitor and complete questionnaires. They send the information to the researchers, and then they get a report with information about how their child sleep compared to other children of the same age, a rating of their sleep based on an age-based algorithm that they've developed, and then they get customized advice on how to have their sleep better at night that emphasizes the importance of an early bedtime, a consistent bedtime routine, and decreasing negative association and developing some positive habits. That intervention was proven to be effective to reduce wakefulness after sleep onset, and it improved maternal sleep and mood. I want to give you here an example of the kind of report that they gave to a parent. So we're not going to read the whole thing, but first of all, it's graphically appealing. You can see pictorially where your child fits on different parameters, such as in terms of total sleep, this is the norm, this is where your kid is, smack in the middle. Longest stretch of sleep seems to be shorter for your kid, and awake at night seems to be longer, and time to fall asleep seems to be shorter than most kids, and number of awakening at night seems to be very short, very low for this kid. And then there's a whole bunch of recommendations that they would give, which we're not going to read. So there are some challenges in implementing these interventions, and we need to think about cultural parenting value and philosophy along the lines of attribution of when a child does not sleep, what is the likely reason? And people are classified into 3 groups. One is those, and it's not mutually exclusive. People can have a little bit of each. So the question is, what are they most likely to be? Some will tend to interpret the infant crying as an infant being experienced distress or anxiety, and therefore the parent should intervene. Some believe that it is important for parents to limit their involvement at night and to help the child learn to sleep on their own. And some attribute it to the baby temperament. It is what it is. That's the quote that I gave you earlier. It is what it is. There's nothing I can do about it. And again, people can hold multiple of those, but those can be addressed individually. And the values, as you can see here, come also with culture. There are some cultures in which everything is guided by the child. It's very child-centered. The parent is not to impose too many limits. In other cultures, limits are very important. Parent to parent, they tell the kids what to do, right? In one of my studies, we have asked both father and mother to complete a questionnaire that had multiple vignettes, and they had to say which one do they think, what statement fits best the situation for them in terms of how the parent should behave. And kind of classified, scored it based on distress, limits, and temperament on each of the subscales. And we asked each of the parents to do it independently. And then when there were discrepancy, we brought the father in, and they discussed why are they different? Because it's very important to have the two parents be aligned, or at least openly discuss their philosophy around this and put it on the table and come up with a plan. Interestingly, there's some research that is showing that whereas in pregnancy, the mother is more tending towards the not setting limits, and the father is more into setting limits. After the baby comes, for first-time parents, the fathers become less limit setting, and the mother become more limit setting, which I think is very interesting. So the other piece, of course, that you all know about is a variety of extinction methods. The components include addressing the cognitions that I talked about and modifying the response. There are three main types of extinction methods that I'll go to get into each of them in the next slide: crying it out, graduate extinction, and camping out. And they are generally very effective. So I'll leave it at that, and I'll move on to the specifics of each of the intervention because I'm cognizant of the time. So the first one is the cry it out, and that is the one that's most difficult for parents to do. It's parents put the child to bed at a designated time, and then they ignore the child until a set time in the morning. They monitor for safety, and that's it. It's very difficult to do, as you all know, and it's effective. The second method that's much more friendly is to have graduate extinction. So basically, the parent puts the kid to bed, may or may not stay with them at all at the beginning for a short period of time, and then leave. And then the parents revisit at certain intervals. The intervals can be will vary from one child to the other, depending on the child's ability to tolerate the separation, the parent ability to tolerate the separation and the crying. And the interval can be fixed, or it can be on a schedule, so every 5 minutes with a timer, or it can be progressively increased within a night or across nights. So there are variety, there's flexibilities of parameters when I work with infants. And the check-in, the important thing is that the check-in involves minimal stimulation. There's a brief comforting, and then you leave the room. And lastly, there's the camping out method, whereby the parent stays with the child in their room until they fall asleep and leave or sleep in their room, and gradually reduce the amount of time they spend in the room. This method takes longer, and it has its own drawbacks for the sleep of the parent, but it has been tested as well to be effective. It's very important to get really comprehensive information before you come up with any plan. I'm not going to go into all the details. I just wanted to impress upon you how detailed. I mean, I basically spent the whole hour just getting a lot of information that I fully understand, all the cultural, behavioral, and cognitive factors that are playing on, and of course, physiological, medical, and so on. So I'll skip that and move to the kind of highlights of the clinical pearls for infant sleep problems. Typically, there is a school of thought that has some support in the literature that when a child has a problem both in the beginning of the night and in the middle of the night, you will start with the beginning of the night, and oftentimes the effect will generalize to the middle of the night, and you no longer need to intervene in the middle of the night. There is a little bit of controversy about that. But the idea, the philosophy behind it is if you, in the beginning of the night, create a sleep onset association where if the kid only knows to sleep when the parent is there, then the kid is going to need the parent when they are not asleep in the middle of the night. But if the kid learns to sleep without the parent, they should be able to self-soothe themselves back to sleep in the middle of the night. And of course, that the process of self-soothing, of teaching to self-soothe comes from this gradual extinction. And if they learn to self-soothe at the beginning of the night, it will generalize to the middle of the night. The other principle that's very important is that this whole process has to be collaborative and feasible. And there's no one size fits all. And I cannot even think that I ever give the same intervention to different families. It always changes. So typically I explain the principles, and I'm very flexible, very creative, and very realistic. And sometimes the parent may be gung-ho and kind of say, I will do it, but I kind of feel that they are not going to be able to do it. So I scale them down and make the plan a little bit more gradual. We consider the personal, cultural, and couple parenting dynamics. And we prospectively identify what could get in the way. And that is very important. Just sending a plan is not going to work in its own because it's complicated. Families are complex. Let me move to preschool children. I think more so than earlier, but it also applies to toddlers. When a child has problems sleeping, either at the beginning of the night or the middle of the night, the challenge is to identify is it fear-based or is it a learned behavior? If it's fear-based, we need to reassure, find ways to reduce anxiety. If it is learned behavior, then we need to work with limit setting. It's usually a mix. However, I would say that limit setting actually can help even with fears. When the parent is appearing to be setting limits, then the kid feels more safe because they have something that protects them in some way. So even when the issue is fear, some limit setting needs to come into place. There's also the problem that emerges in refusal to going to bed. And there we intervene with strengthening the parental authority and limit setting skills, developing very realistic and clear rules for bedtime that are consistently followed, and the introduction of a positive reward system or a pass system to give some power to the kid. That a pass would mean that they may have 3 passes a week, and if they use a pass, they'd only have 2 passes for the rest of the week, right? So they can go and ask for parent help 3 times a week, but no more. And slowly they learn to kind of some autonomy around the issue of going to bed. The thing about positive reward is very, very tricky. There isn't a universal positive reward, and something that was positively rewarded time A might lose its reinforcing value later on because its value gets diluted. So it's very important to identify what that might be. It's always important to engage the child in developmentally appropriate manner. At the very least, get the perspective of the child of the problem. Do they even have a problem? What is it that they want to change? we typically, I typically at a low developmental stage, I would come up with a plan with the parent and bring the child in, explain to the child what the plan is so that they understand it, or help the parent rehearse how they would bring the plan to the kid and how they explain the plan to the kid. There's also the issue of use of technology. It's not necessarily an issue. You can use it positively. So for example, in this case, the toddler alarm becomes extremely helpful, and I'm sure most of the pediatricians in the audience use it for making sure that the kid doesn't end the night too early and come to the parent bedroom. So as long as this clock is still night, you don't come you don't wake up us, you continue to sleep, etc. And a timer is, in terms of technology, is very important when you are doing any of the extinction methods, because time estimation when you are distressed and a kid is distressed is not very good. And so any questions about this age group?
Well, thank you, Dr. Member. And since you just mentioned about timing, one of the questions we have is, what is an appropriate delayed response time based on an infant? Do you have any guidance for that?
I would say a minute.
And then what about for a toddler? What's the time that you think is generally what you'd recommend?
I don't have a general recommendation for a toddler. I kind of tailor it to the family and to the kid and how much they can tolerate, how they self-soothe at the daytime, what kind of skills they have. I would typically start with 5 minutes, just to give you the scale.
Yeah,
but not rarely more. There comes a point in that process whereby the parent realizes that them going to check, actually they wake the kid more because the kid was about to fall asleep and then they came in. So that is clearly a signal that the interval needs to be lengthened.
Great. Yeah, no, I agree. I think it needs to be a little bit individualized. So I usually kind of come up with the number together with the parent as well, just to get a sense of what seems reasonable. But I loved your point about if you catch them when they're actually about to fall asleep, then you've kind of undone what you just did.
Right.
So a couple other questions. There's a question about if cutting a child's nap throughout the day, kind of reducing the nap, is that good for helping them sleep earlier at night?
It could be. It's very tricky. I relive that now with my grandchildren when they got through the phase of that. It's very tricky because if you let them sleep, so that the piece about the napping is, think about the sleep. I'm glad we talked about the sleep regulation. If you think about this homeostatic sleep drive, if the nap is until very late, there isn't enough time to build it. And so the trick is to try to push it to an earlier time and also to limit how long it is. So the kid might still need a nap, but maybe you should not be afraid to wake them up so they don't sleep for too long, because then it will interfere. So it's kind of a song and dance of finding the right balance. Because the longer they sleep, the less sleep drive they'll have later. And the later they sleep, the less time they have to rebuild their drive, right? So we work on both of those.
Great. Yeah, thank you for that. We have a lot of questions. I'm trying to see if I can kind of group them by, we have really keep them coming, everyone. This is wonderful. I'm going to go back to a question that kind of changes back topics a little bit to the sleep regulation. There's a question we had about how to prepare for time zone changes, for instance, going from the US to China. You kind of touched upon it a little bit, but I was wondering if you had a few more tips for.
I would just say, I actually, it's a big topic and I don't think we can do it service in this limited time. My philosophy is go with the flow. I remember my kid basically walking away, it was daytime, walking and almost asleep while walking. So it's tricky. It's tricky.
Yeah, I agree. I think planning.
I'm punting that one. Sorry about that.
I'm sorry?
I'm punting that question because
no,
it's complicated.
It's a whole nother talk in of itself. That's a great question. But I think, yeah, go with the flow and give yourself grace, knowing it's going to take a while. I have another question I think we're going to get to a little bit, but what modifications would you make for a toddler who has autism spectrum disorder?
I would emphasize more the boundaries. So depending on how highly functional they are, if there's any group that has been studied more than other, it's the autism group. And I have quite a few kids in my clinic right now with autism at different level. A lot of behavioral analysis and a lot of behavioral contingencies. So it's really, I don't think I have a universal answer for just because you have this diagnosis, you have to do this, that, and the other. But I would say you would rely more on the behaviors, and the consistency is going to be extremely important.
Yeah, thank you. Yeah, it's definitely one where I guess in the individualized nature of the treatment, I think comes into play. But you're right, just because they have autism doesn't.
The limit setting, I would say, is number one. I've seen wonders happen with the limit setting.
Absolutely.
And the beauty of it is this generalizes to other domains. When the parent has the resolution and the skill to set limits around sleep behavior, it somehow, the kid is better behaved during the day, and the parent gets the idea and generalizes the skill also to other domains.
Mm-hmm. That's great. Yeah, limit setting and routine, I think, tend to be really key. So a couple other questions about sleep association. There's a question about, so if a child is still able to sleep well through the night, are there negative impacts on children if a parent co-sleeps with them when they're age 7, 8, or even older?
I would say, if again, that's where the culture comes in. If it's not a problem to the child and it's not a problem to the parent, there's not an issue.
I love it. Agree. And then another question, this is one that I think many people will have, is how do you break that cycle of being overtired in the infant toddler age group, resisting naps, not easily going down at night, and you feel like the parent is kind of in this spiral, the kid's in this spiral? How do you start to break that cycle?
I think I start by imposing a rest time. So you are not supposed to be sleeping, but it's your quiet time. So I will basically impose quiet time. And the door is shut, and there's music, and there's darkness, and the kid can listen to music, and the kids can look in a book, the kids can color, but they need to be quiet and be by themselves without parent attention, and just being by themselves, just bringing down the whole tone down, and then increasingly increase the length of time that happens. And if the need is there and the kid is quiet, the kid will fall asleep. The key is to remove the struggle, to set very firm limits, right? That this is a rest time, and that's it. Whether you sleep or not, I don't care, but this is your rest time. And then sleep happens.
I love it. Yes, no, the rest time I think is key, and I do agree. Oftentimes kids will kind of fall asleep during that time, and it kind of almost brings them some autonomy with that too.
Right.
So I maybe could do one more question, and then we can let you continue on. So we had a question about, sometimes there are additional caretakers like a nanny or grandparents who may put child to bed if the parents are at work. So how do you get them on board with the plan? How do you counsel parents to get everyone on the same page?
You explain what the expectation is, and you discuss, you put on the table the disagreement. So if the parent prefers not to do it based on principles, then you discuss these principles and you ask them to do it in a different way. If they understand the principles, but they cannot bring themselves to do that, you try and find what is the problem for them and try and help them. But most importantly, remember that the kid could learn to behave differently with different people, and that is okay. It doesn't have to always be consistent across every human being, but within an interaction, if I'm the one who set limit, I need to be consistent with that limit. And if another person had a different limit, they will be having this different limit, and the kid can live with the fact that different people have different limits. Okay, so with that, I think I really should move on so that we have time to talk about about older kids. So when you start talking about older kids, you really get into the world of how insomnia is treated in general in adult population, because the same principles apply here. So the one more slide that I want to more general thing is to talk about the evolution of insomnia in general. And this is very helpful when you get older kids. So if you think about this line as the threshold for insomnia, and you think about the bottom line in here, the bottom line is the predisposing factors. So people come into the world with different level at which their sleep is sensitive to what happens in the world. Like if there's if people in this area had different levels of how much they lost sleep over the election, right, etc. Then typically superimposed on that, there is a precipitating factor. So typically an event happens that causes most people to lose sleep over, such as economic stress, deployment, loss of a relationship, loss of a loved ones, pandemic, right? So increased stress of some sort that's acute. That stress interrupts sleep. In response to not sleeping, people start engaging in a variety of behaviors, some of which make the problem worse, so much so, and that is the perpetuating factor, that even after the stressor comes down, the problem is still maintained, not because of the stressor, because they have adapted to it, but mostly because of this extra layer of the measures that they've used to help themselves are actually backfire, making things worse. So a good example for that is the tendency to cast a wide net. Since I cannot sleep, let me stay longer in bed so I can get more sleep. Well, we actually use time in bed extension as a model for creating insomnia. The longer, if you sleep well for 8 hours and I bring you to the lab to sleep for 10 hours and ask you to sleep for 10 hours, by the end of the week, you start having insomnia symptoms, okay? So the target, the CBT for insomnia, ends up focusing to a large degree on this green section. I am cognizant of the time, so I'm going to be very brief in my description of what cognitive behavioral of insomnia entails. There are essentially building blocks, or the Legos of CBTI, and they include something we call stimulus control, which I'll talk about briefly. And its aim is to strengthen the bed, so to unlearn the association. So somebody had a question about that, so that's the answer. The second one is sleep restriction, which I really don't like, but I kept the name because that's how it's in the literature. I call it time in bed restriction, because we basically restrict the time in bed to increase the sleep drive and consolidate sleep and slowly increase it. And I have a slide on that. Then there's a whole bunch of interventions to address the arousal system. There's cognitive therapy to address the beliefs and thoughts about sleep that actually run interference with sleep. And then there's this thing that people call sleep hygiene, which I don't like because people also tend to equate sleep hygiene with CBTI. Sleep hygiene alone is often used as the control intervention when testing CBTI. So you can't equate the two. And basically, the sleep hygiene refers to addressing substances, exercising, sleep environment, eating in relation to sleep, etc. Devices. And then there's a circadian rhythm entrainment when needed to shift and strengthen the biological clock to make sure that it supports sleep. And so all of this is brought together in a case formulation way based on a thorough assessment. So stimulus control is a fancy name, but it comes, it refers to the following 5 components. You get a consistent rise time regardless of how much you slept. So you dissociate, you stop like giving yourself the casting a wide net. You go to bed only when sleepy because that increases the probability that you will sleep. You get out of bed when you are not able to sleep, or at least you stop trying to sleep by doing something else and stop trying to sleep. You use the bed for only sleep and sex. You remove the sex for the kids. And then you do not take daytime naps to increase the likelihood of a strong sleep drive. So of course, the daytime naps would not be, you do not take it, but you limit it. But for adolescents, it will be do not take it, right? So depending on the age. And the idea, as I said, is to strengthen the bed as a cue for sleep and to reverse the conditioned arousal. The sleep restriction or the time in bed restriction is essentially the following. You start sleep that looks like that. You add up all the S's. And let's say this is 8 hours and all the S's add up to 6 hours. I'm just inventing that. It doesn't match the figure. So then you tell the person, okay, now limit your time in bed to only 6 hours because that's how much you sleep anyway. So like just, you may sleep a little bit less because you won't fall asleep instantaneously. But what happens is you squeeze out a lot of the wakefulness, both at the beginning of the night and in the middle of the night. And when that happens, you start expanding it. You expand it by 15 or 30 minutes, depending on how abrupt you've done the restriction. And gradually increase it until at the end, you sleep the same amount that you slept. You sleep more than you slept before with fewer awakening. There are several caveats to that, and that you need really close follow-up when you do that. You never want to restrict sleep in adults below 5 hours, in pregnant people below 5.5 hours, and in children, in children and adolescents, I would never restrict it below 7 hours. This is a very effective intervention, but it needs to be exercised with care, and there are alternatives to that. There's something that's called sleep compression, where we go, instead of restricting and then slowly expanding, we start with a lot, we restrict by a little, see how much we get improvement. We restrict a little bit more, see how much improvement, and then we might never need to go to the level of restriction that we would have done as a first step for that sleep restriction per se. There is cognitive therapy, which I really am not going to get into because this is really psychotherapy. You identify sleep interfering thoughts and beliefs, you address sleep effort, and I'll show you a little bit about that. You conduct behavioral experiment and you use what we call motivational enhancement. So that it also bleeds into how to calm your mind to go to sleep. So to address sleep effort, I actually have, even during the time that I now do everything with Zoom, I used to have this Chinese finger trap in my office, and I would have the kid put their finger in the finger trap and they would love it. And they would understand the idea that pulling harder, trying to sleep harder doesn't work, relaxing into it is helpful. And the key here is that parents, in their concern about the fact that the kid will get enough sleep, and the kid is trying very hard to do what the parent wants them to do. And as a result, they contract the anxiety about sleeping. And so if they can't sleep, they become anxious about not sleeping and they try harder to sleep, which makes it harder for them to sleep, right? So the whole family needs to relax around it. And that is an important piece for improving sleep in children. Avoid monitoring time because it creates sleep anxiety, a performance anxiety. And don't overfocus on sleep. Don't ask the kid in the morning how well you slept. Don't make it such a focal point and such a worry point or such a concern, because the kid then becomes saying, I'm too tired to do this and I'm too tired to do that, and the parent buy into that. Also important, just as you do with young children, to have a period of an easing into sleep period. We call it a buffer zone or a bedtime routine, if you wish, a period free of high stimulation, excitement, worries, tension, that allows the unmasking of sleepiness so that sleepiness will emerge and sleep can naturally unfold. However, don't make it boring. Make it something that the kid can really enjoy for its own right, rather than as a means to an end, and is calming. It's not activating. There are some relaxation methods, relaxing music, back rub, lotions and potion, guided imagery, breathing meditation. Increasingly in this area, I have kids come that listen to some of the sleep bedtime stories or some sleep meditation content, which is perfectly fine. And you want to block the blue light on devices. So the devices is a whole big thing in its own right. So I devoted a whole slide for it. So I very much respect parents' philosophy about how much they want to expose, how much time they let the kid have with the device, depending on on the family values and the kids' tendency, like to overuse it and the limits that they set around it. But at the same time, I also see the device as a potential way to help the kids self-soothe on their own. And so, for example, I remember a preteen who could not, the issue was really stuff that was going on in her mind, and she couldn't fall asleep because of that. And I convinced the parent to let her watch YouTube, and she watched DIY YouTube content of makeup, and that has calmed her. And so every night she would watch a little bit of that, she'd become sleepy and she'd fall asleep. The duration of that was very short. It was less than half an hour, but it was very helpful. It was really a pivotal point for her. So it's not, I don't like people totally vilifying devices, because if used properly, they could be actually helpful with sleep. So the negative impact of the device could be that the blue light that is emitted from electronic devices is alerting and could alter the circadian clock and its regulation. It can push a light that I will show you a slide about that later. A light that is in the evening delays the whole clock to a later time, and that's the last thing you want to do. So the solution for that is technical. You just, oops. What did they do? You just put a blue light blocking on a timer, say 7 p.m. to 7 a.m. The activities in which you engage in could be alerting. So if you watch this kid that I gave in the example, that is calming. But if you are watching a suspenseful movie, that is a problem. Or if you are, the alerting can also result from using the device in bed it creates a learned association with alertness, and it could be too activating. So if it is too activating, just don't carefully choose the activity. Don't do video games. Don't talk to friends. But if the concern is about the learned association because the kid cannot disengage from that, and some kids cannot, and parental control only has so much limit, you simply eliminate the device from the bedroom. I'm sorry for the typo in here. So moving to the preteens, the principles are pretty similar, and it's also true for kids, for teens. Fears or learned behavior, it's usually a mixed. We talked about that. Engage the child, we talked about that. Only when you get to school-age kids, you actually talk a lot about, does the kid perceive this as a problem, or is it that the parent perceive it as a problem only, in which case you have much more work to do to bring the kid on board. What is the child's goal, and what are separately the parent's goal? How much does the child want the parent to be involved in the room when you're working with them? Or how much is it wise for the parent to be in the room? It's a clinical judgment. And you involve the kid in the treatment plan. You tell them about the principles, and you have them in a way that they can understand, even the sleep regulation, in a way that's watered down, in a way they can understand without these complicated graphs. And you talk about the technology used in the bed, the blue light blocking, careful about content. As I said, respect parental values and concerns around the use of technology. So these are principles that we already discussed. I'm bringing it together to this age group. If the issue is primarily fear, then what we do is we create a hierarchy of fear of what is the person afraid of, and you start doing exposure from the lowest to the highest. And that is done to promote mastery. So as an example, I had a 10-year-old who was afraid to be upstairs alone, to go to sleep alone, because they're afraid to just be upstairs alone. So the lowest item in the hierarchy was to just go upstairs with his sister for a few minutes to show her around and to check that everything is safe for her. And slowly increase the mastery of what tasks the kid did to overcome their fears. When it is learned behavior, then we use things like the stimulus control that I talked about earlier, and you use a time in bed restriction. When it is the busy mind, we distinguish between sleep-related anxiety, in which we conduct some cognitive therapy to address them, or if it's laying in bed, being anxious, not necessarily about sleep, but about life stressors, in which case we talked about managing stress and time and creating this buffer zone to address that. The one thing we did not talk about is nightmares. And if the nightmares are present, we use a technique that's called imagery rehearsal therapy, which again, I don't have time to get into right now, but I would say that most commonly, if there is insomnia and nightmares, not just nightmares, treating the insomnia oftentimes resolves the nightmares because there's no awakening, because the arousal threshold becomes stronger or higher. So moving to adolescents, and I'm realizing my time is running out, I want to focus on the circadian system. So the challenge in adolescent sleep and circadian factors is to distinguish with when it is biological and when it is behavioral. So not all adolescent behavior around going to bed late and waking up late is biologically based. Although I would say that there is research showing that the gene expression for the longer endogenous, longer allele for the circadian period is expressed during later TANA stages. But they don't underestimate the behavioral factors and the social jet lag that occurs. And the key is to make a differential diagnosis. Is it an insomnia disorder or purely a circadian rhythm sleep disorder? And one of the distinguishing factors, I have the wrong animation here, so I'll put it in here. The circadian rhythm sleep disorders is due to a misalignment between the endogenous circadian rhythm and external factors. But really, the more important one is this slide in the interest of time. So how do you tell the difference between, is it a delayed sleep phase issue? Is it an insomnia person that just has a little bit of a later clock? The difference is that a person who's purely just clock issue, they only have a difficulty if they go to bed early. If they go to bed later, they sleep fine. So if you allow them to go to bed late and wake up late, they sleep absolutely fine. They have no problem falling asleep. They don't have much problem waking up. On the other hand, for people who have insomnia, they have difficulty even when they go to bed later, but somewhat less of a difficulty. So to address the circadian factors, it is extremely important to have a regular rise time because that entrains the clock, as we talked about earlier. And people who have a delayed type need a longer time to unwind for the day because their activation at the beginning of the night is due both to the arousal system and to the circadian system. Bright light can be used, and I have a slide on that, the next slide on that. The morning light exposure in the morning and avoiding bright light in the evening. We talked about the latter. I'll show you in the morning, you want to do it as close to wake time as possible, and sometimes even waking up earlier than usual. There is a dose response curve that I have a slide on, which I'm going to skip because we don't have time. But basically, the timing is ideal if you want to advance the whole clock to an earlier time around the habitual rise time. But it has to be after we estimate the temperature minimum has been reached, because if you do it too early, then you're switching the person to the wrong direction. And the light intensity, 2,500 lux to 10,000 lux, 30 minutes to 60 minutes. There's a research showing that 30 minutes is plenty. And the blue wavelength does the best result. So if you think about, if you want to phase advance, what you want to do is you do light in the morning, darkness in the evening, and you advance the whole rhythm. And you do the opposite for the achieving delay, which you don't need to worry about with your population. But if you have light exposure you want to avoid light exposure in the evening if you don't want to push that. If you do light in the evening and darkness in the morning, then you achieve a phase delay. So when I work with adolescents, I want to promote autonomy I want the ownership of the problem to be the kid, and the parent will be the support system, only as asked by the teen. I address circadian factors. I added in here to the circadian factor A, we talked about reducing, minimizing variability between rise time on weekdays and school nights. And here, because so many kids are sleep deprived on school nights, I do allow some variability, but no more than 2 hours extra sleep, latest sleep on the weekend. Talking about light and dark exposure that we talked about, including devices. But I added here the low dose melatonin because melatonin is oftentimes, we have not talked about it at all, but you pediatricians prescribe melatonin often for helping kids sleep, usually at higher doses. At a low dose, when it's not given at bedtime, but it's given 5 to 7 hours before bedtime. And that allows to delay the clock. And there's some nice research showing that when you do both light exposure in the morning and melatonin before in the afternoon, you can shorten the amount of time that you need the light in order to entrain the rhythm, which is critical for teens because they have to go to school and there's only that much time in the morning that they can do the light exposure. And then you do CBT for insomnia, which I am going to leave more time for questions rather than discuss. So I have a case example, which I'm not going to show you because we ran out of time. I'm going to thank you to tell you that if you want to get help for pediatric sleep, I practice a sleep health and insomnia program spans both Stanford Healthcare and Lucile Packard. This is our website. And for children, you can refer directly to LPCA Child Psychiatry. If you have teens, you can refer them either through the adult or through the child system. And I thank you for your attention and the few more minutes we can spend on any questions that you have.
Great, thank you so much, Dr. Mann. That was so helpful. We do have a couple questions I think I'm going to see if we can try to get in the last minute. One question was, are we fighting adolescent biological clocks by starting high school and middle school very early in the morning?
We're not fighting it, but we are going against it. There is evidence that, and there have been experiments, and there's data that starting school later gives adolescents more sleep.
Great, thank you. And then just in the last minute, there's a question about other resources that you actually recommend for parents, especially that can offer some personalized help. Is there anything online that people can refer to in addition to a sleep doctor?
I am not aware. I'm not ready with resources for that. It's a great idea. I should dig in and compile and share. I don't have it. I'm sorry.
That's okay. And then I think we just had one question about can hyperaroused behavior be retailored later in life? I think the answer is yes. Obviously, if you have insomnia, you can treat it at any age. So hopefully that helps. And then I think we had a final question I think is unfortunately just probably not in scope that we can do is about teens and marijuana. How can we help them if they utilize it to sleep? And I think generally it's not recommended to use marijuana for kids to sleep. I think that's something we can say, and there's not a lot of great research, I think, about the long-term effects of marijuana in children. So I don't know if you wanted to.
Well, there isn't enough research on cannabis in general and sleep. I would say CBD and at least 50% CBD in adults seems to be helpful clinically. Research is lagging on that. I think there's some trials ongoing right now, but there is nothing that I know of in children or adolescents.
Thank you so much. That was really wonderful. I think we're going to end it now. I'm trying to find. So I wanted, as a reminder, we have a session this afternoon. Well, first I want to really thank Dr. Manber for really her time and her expertise in this topic. It was just really wonderful. And then for those who can join us, we have another session in the afternoon on pediatric urgencies and emergencies at noon Pacific time with Dr. Sherelle Smith. And then tomorrow is our last day of our Children's Week. So we're wrapping up with a session on return to play and common reasons for acute pain consultation. So please join us for all that. And I want to thank you again for your attention and for Dr. Manber's great teaching.